It's always interesting to know that a lot of drugs, they hit the market because it's not something that was planned. We can talk about Viagra, sildenafil, obviously a pretty well-known medication for erectile dysfunction. That was not the original purpose, right? That was blood pressure, and so we find so many things. I believe that finasteride for hair loss is also someone found out that there was a benefit for hair regrowth or stalling hair loss as opposed to prostate benefit. I mean, there's still prostate benefits, obviously, but it got marketed as a hair loss medication at a lower dose, and that just happens so often. So repurposing is something that is common based on real life observations that may be actually not even intended, right? It's just you get lucky.
As providers, is that something that you look for when you are deciding what treatment modalities to use? Are you looking for compounds with multiple therapeutics or therapeutic benefits?
Absolutely. It's really common that we pick, for example, with diabetes medications, you pick one that has another benefit. For example, you pick one that has a weight negative effect to help with body recomposition and weight loss, perhaps prevent bariatric surgery. Even with, for example, let's say topiramate, you're also looking for, you might have a benefit of mood stabilization, but a detriment of kidney stones. So if you have a history of kidney stones, you're not near as good of a candidate. So you're certainly looking for secondary benefits. Perhaps someone has a bit of adult ADHD and they do better on Contrave or something with bupropion in it. So you're certainly looking for other indications. I think one thing that we run into quite often is the patient is actually looking for other indications. For example, perhaps a patient comes with us and they have a borderline hypertension and they're asking us about, they actually do quite often, a low dose of telmisartan, because it's not only an angiotensin receptor blocker or an ARB for blood pressure, it's also a very weak PPAR delta agonist. And maybe they're a marathon runner and think that even that tiny bit of PPAR delta agonism has a fringe benefit.
That's really interesting because I think this is the patient population that you see combing through WADA's watch list every year. They're like, oh, what could possibly have a performance enhancing vector here? So you have people that say, oh, there's a little bit of PPAR delta agonism, and there are more potent PPAR delta agonists, which we've spoken a bit about. Cardarine is a research chemical that people are using that has significant cancer risk in preclinical models, so it was essentially scrapped altogether as far as delving into that for cardiometabolic benefit. But looking at long-term, thinking if somebody is an athlete, they're trying to push the limits, they're in their 30s and they say, oh, I'm going to take this telmisartan. Well, then maybe they do go on to develop hypertension. Do you want them to have 60 years of low-dose PPAR delta agonism, or whenever your immune function starts to decline and your tumor suppressor genes are mutated, when you get into your, let's say, 60s, just ballpark, would you switch over to a medication that does not agonize PPAR delta? And that's where the nuance gets really fun and really interesting for myself.
Definitely agree. It's a moving target across a lifespan, and often when you're thinking about true preventative medicine, you're finding something that has efficacy, but it is often not very strong or a high dose. Statins are a pretty good example of this for individuals with familial hypercholesterolemia. There's been studies, I believe there's one in Korea, looking at specifically ages 19 to 39, and then they looked at ASCVD, or heart attacks and strokes essentially, later on in life, in the group that did something for lipid control versus nothing. So doing a very small amount for a long period of time can be a better option than waiting until you have the end pathology. So you're doing, instead of primary prevention, it's secondary prevention, but then it's not really even prevention. It's just secondary prevention, you're just preventing recurrence. And often you require much stronger medications, much higher doses, and those have many more side effects.
Yeah, by the time you have a vascular event, you already have atherosclerosis and substantial plaque buildup in the arteries. That is very hard to reverse. You can see some statistically significant reversals. Usually those are with high intensity statins, the addition of PCSK9 inhibitors, or even some very, very low fat plant-based diets, which a lot of people don't like to hear about.
So as a provider, what would be a low dose that you like someone who is in their 20s or 30s, seems to be at risk? How low do you like to start with something like rosuvastatin?
Often I start all the way down with rosuvastatin at 5 mg, sometimes even half of that, which is 2.5 mg.
Daily.
Often even less than daily. There's a study, KU, University of Kansas was one of the institutions, but several of these institutions looked at every other day or 3 times a week administration for statins. Each statin has a longer or shorter half-life. So rosuvastatin is almost a week, whereas some statins have a very short half-life. So depending on the situation, we like to look at the ApoA1 to ApoB ratio, and often a lipo profile to look at particle sizes as well. Oxidized LDL. So after you, for example, that's in the example, this person has familial hypercholesterolemia, or perhaps they just have a significant dyslipidemia. You want to look at more parameters rather than just an LDL.
The ApoA1 to ApoB ratio is a really good indicator. This is from old data, actually, the Innerhard trial. And what I found most striking about that is the highest quartile of ApoA1 to B ratio, people with the highest apolipoprotein B levels, actually had a higher hazard ratio than your average smoker. Now, you could certainly exceed that depending on the volume and the time of exposure to the cigarettes, the smoking. And probably the same is true. A good way to look at cholesterol is your time of exposure. So have you had an elevated apolipoprotein B since you were 18, or did you just develop this in your 40s when you started to have metabolic dysfunction secondary to something like insulin resistance or obesity?
Absolutely. This is why you see a lot less lipidology clinics. They're changing over to cardiometabolic clinics. Instead of trying to separate the same field into 2 different halves of the same coin, it's just a cardiometabolic clinic.
It's really interesting to do all those testings with Gillett Health when we look at complete health and cardiac health. We look at everything, right? We just cannot prescribe a statin based on LDL-C and HDL anymore. You really want to look at the lipo profile. You want to look at particle size. There's a very interesting debate, obviously, about cholesterol, where people will say, well, LDL is just, it doesn't matter, it doesn't really mean anything. And I'm always playing devil advocate and saying, okay, well, it doesn't matter, but let's look at the lipo profile. And then it says your particle size is totally inflammatory or associated with inflammatory. And maybe your oxidized LDL is high and your small dense LDL is also high. So are we going to still say it doesn't matter, LDL doesn't matter? And you want to have the full picture. You cannot just guess based on LDL. I get it, but we definitely want to test for more, and that's pretty much what we do. And the ApoA1 over ApoB ratio is very important as well. I think that should be pretty standard before getting anyone on a statin. And it's very interesting when we look at the results. You can have, I mean, it's quite rare actually. You can have a pretty good LDL over HDL, the basic lipid panel looking good, and then for the rare people who say, well, I just want to test everything, and then you can have a good LDL and then oxidized LDL is through the roof. I've seen that recently. So you want to work on obviously antioxidant / oxidant ratio of you want to make sure someone is, why are they oxidizing that much? So, and what about the antioxidant? But it's interesting to see a lot of people saying, well, LDL doesn't matter, and now we test for more and everything is in the red. So when does something stop to matter?